Good morning. Welcome to Grand Rounds. I am pleased to introduce Puja, who will be giving our talk today about the beloved patient. Puja is very nervous, so she really didn't want me to read anything on here to introduce her. But she is a physician fellow with the Pediatric Palliative Care Program at Dana-Farber Boston Children's and is part of our Harvard Interprofessional Palliative Care Fellowship, and it's been tremendous to have her with us. She really didn't want me to share that she went to the University of Arizona or went to medical school at Mayo and was a resident at the Boston Combined Residency Program, where she was part of the Urban Health and Advocacy track. Her research interests include disparities in the patterns of care received by pediatric patients at the end of life, and so I think this talk will fit into that theme. And she's been a phenomenal fellow with us, so please welcome Puja.
Good morning. I'm really excited to be here today, a little bit nervous. But today I'm talking about a topic that I have spent a lot of the months of my fellowship thinking about, and it's titled The Beloved Patient, Learning How Far I'll Go and When to Let It Go. For those that don't have young children at home or don't work in a children's hospital, How Far I'll Go is a song from the movie Moana, and Let It Go is a song from the movie Frozen. And this will become pretty apparent quickly as I go through my case. I have no disclosures to disclose. My learning objectives are that I hope that you'll end this hour able to define beloved patients and to identify patients in your own practice that fit this definition. I hope that you'll be able to identify the possible pitfalls that come from caring for beloved patients and to develop a framework for overcoming those. And then I hope that you'll be able to describe the implications that caring for beloved patients can have on our own well-being. So to introduce you to the patient that inspired this talk, AF. She was an 8-year-old girl with multiply relapsed progressive Wilms tumor. She was diagnosed at the age of 4 and had spent much of her life in and out of the hospital. This last summer, she was admitted to Boston Children's with a partial gastric outlet obstruction, and our pediatric palliative care team was consulted for symptom management, specifically nausea and pain. This shirt was one of her favorite shirts, and she wore it often in the hospital. For those that can't see it, I'll read the lines on it. It says, bold like Ariel, brave like Rapunzel, smart like Belle, kind like Cinderella, and strong like Mulan. We would often joke in the room that the 6th line on this shirt should have been feisty like AF. And she was adored. She had a long-standing relationship with her primary oncologist who had had her since the first days of her fellowship. She was known well by our inpatient nurses on the oncology floor after multiple admissions. And for those that didn't know her well, she captured your attention easily. She had one of those easy smiles that warms your heart. She had an impressive evil laugh that shook her entire tiny body. She had a love for singing, particularly songs from Frozen and Moana. And this is a picture of one of my co-fellows, Peter, getting ready to belt out Let It Go with AF. And to top it off, even on their hardest days, her family, particularly her mother, was extremely kind and gracious for all of the care that AF received. I intermittently took care of AF from July to September of my fellowship. And as a new fellow, AF's life and subsequent death affected me in a way that I wasn't anticipating. I would think about her and her family often. I would log in to check our EMR even on weekends when I was off. And after she died, I experienced feelings of grief. I found myself wondering why AF had affected me so differently than other patients had. And I wondered if it was okay to have such strong affection for a patient. Sue Morris, who's a psychologist at Brigham and works with the fellows in that role, has taught us this year about the concept of a SUDS meter. SUDS stands for the subjective units of distress. And she encourages us to explore why it might be when we feel that meter rising. This chalk is essentially the product of that exploration, and I'm excited to share it with you all. So to answer my question about whether it's okay to have strong feelings about our patients, I looked first to the literature. It turns out that very little literature exists about well-liked patients, beloved patients, favorite patients. And so in order to develop a better framework for this concept, I examined the breadth of literature that exists about the difficult patient. The first article to acknowledge that, yes, doctors do have strong emotions to patients was this 1978 article in the New England Journal by Dr. James Groves, who's a psychiatrist here at MGH. He describes that not only do physicians have strong emotional responses to patients, but that these emotions can have effects on both the physician and the patient. I think I just want to pause here and note that a lot of the literature that I'll go through during this talk talks about physicians and doctors, but I think that their messages can be extrapolated to all clinicians. So Dr. Groves defines the hateful patient as one who most physicians dread, who kindles aversion, fear, despair, or even downright malice. He describes 4 phenotypes: clingers, demanders, help rejectors, and deniers. And the most important point that I think he makes in this paper is that these feelings may result in an unconscious punishment of the patient and self-punishment of the physician because of the guilt and inadequacy that we might feel in exploring these emotions. There have been many articles published about the difficult, hateful, or heart-sink patient, as they're referred to in the literature. The Hateful Patient Revisited is a review article that was published about 30 years after Dr. Groves' initial paper. And in this article, the authors examined the relevance of the hateful patient in the 21st century. The authors describe that the patient-physician relationship has not diminished over time. There are patients who still engender strong negative feelings, and that today this is confounded by technology and changes in our healthcare delivery system. They describe that the patient-clinician relationship has shifted from one of blind trust to one of informed trust, as patients have easy access to internet and other resources. They distinguish that it is not the patient that's hateful, but the patient-clinician interaction that provokes strong negative emotion. And they suggest that effective communication, particularly focused on understanding the patient's experiences and fears, is one way to work through this emotion. While there are few papers about well-liked patients, this is a study by Dr. Hall at Northeastern, who looked at the patient-physician dyad. She studied patients and physicians and surveyed them after a medical visit about how much they liked the other. What she found is that liking is mutual and that we are pretty good at telling when patients like us, and the patients are pretty good at telling when we like them. A physician's liking for the patient in this study was associated with better patient health, a more positive patient effective state during the visit, and interestingly, the patients that physicians liked reported more favorable ratings of physician behavior and visit satisfaction. I think, again, demonstrating that mutuality. I think that patients that are likable are still different than the patients that we hold most dearly. And for that, there really is a paucity of literature. This data is one of the few studies that I was able to find examining primary care family physicians at Johns Hopkins who were surveyed or interviewed about their favorite patients. And 22 of 25 primary care physicians reported having favorite patients. The 3 that denied having favorite patients had an issue with the term and felt that it implied acts of favoritism. The themes that emerged when asked about their favorite patients were that these were long-term patients, patients with significant illnesses, and patients with whom the physician had had an experience that strengthened their bond. They had overcome a crisis together. The physicians in this study noted that while positive relationships can be sustaining, losing these patients is painful. And they noted an awareness of having of these patients' effects on clinicians helped them to keep a check on themselves and to provide appropriate care to all of their patients. So with that review of the literature and a realization that there's really not a lot that exists about this concept, I'd like to propose a definition about the beloved patient. The beloved patient is a patient who evokes a strong positive emotion that makes it difficult to maintain the traditional patient-clinician relationship. And I think that there are some patients that are beloved by many, and some patients that are beloved by just one or two of us. And why that might be, I'll get to in just a couple slides. So for the next part of this presentation, I invite you to walk with me, to think about one of your own beloved patients and to reflect on that experience as we go through the rest of these slides. In a 2001 JAMA article by Diane Meyer, the authors propose a model to help clinicians identify and work with the emotions that come from working with seriously ill patients. While she talks about the predisposing risk factors for all emotions, both positive and negative, I've adapted the table from her paper to think more critically about the factors that predispose patients to being beloved. And I think that you can divide these factors to clinician factors, situational factors, and patient and family factors. So clinician factors, you can imagine that when you identify with a patient, that predisposes them to being beloved. You can imagine that when a patient reminds you of someone in your own life that you care about, that predisposes them to being beloved. And then I think that when we have unresolved feelings, either professional or personal, those feelings can predispose to having beloved patients. Situational factors, as alluded to in the Johns Hopkins study, are patients that we have a long-standing relationship with and patients who we've gone through an experience that strengthens our bond with. And then there are factors that are patient and family specific. Patients that we find to be really brave or courageous, the underdog patient that really is beating all odds, patients that have positive affects, and patients that express gratitude and appreciation. And with that, I present my hypothesis that beloved patients can affect the care of patients and influence clinician well-being. And first, I'll focus on the care of patients. I'd like to talk about three possible pitfalls that come from caring for beloved patients. The first is boundary crossing. The second is countertransference and really not attending to countertransference. And the third is the possibility that there may be differences in care received by beloved patients. And we'll walk through AF's case to examine these three pitfalls. So to go back to AF, our initial role with AF had been symptom management. And when we would visit in the mornings, we noticed that she was often sleeping during our visits. So as eager, excited fellows, we started to visit also in the afternoon when she was more awake. And we initially used dance parties and sing-alongs to do our symptom assessment. If AF could dance and raise her shoulders, then her pain was well controlled. If she could sing, then her nausea was probably not so bad that day, and our medicine was working. And in the beginning, this helped us to have a better understanding of her symptom burden, and also it gave us an opportunity to build rapport and a connection with AF and her mom. As AF's symptoms stabilized and we were making less frequent changes to her medications, we continued to prioritize AF high on our must-see list for the patients that day. She had had recent scans that showed disease progression, and we initially thought that our continued visits would give us an opportunity to talk to her mother and to see how she was thinking about this clinical change in AF. At the same time, in retrospect, I realized that we also continued these daily visits because we felt that most days we were able to brighten her day, and she definitely brightened our day. As a recent graduate from a busy residency program where I spent most of my time behind a computer, I also recognized that I was craving an opportunity to connect with patients and to get to know patients on a better level. One day during rounds, our social worker pointed out the frequency of our visits and asked what the goal of our visits were, subtly highlighting that perhaps we had lost track of the palliative care work in the room. By pushing us to name our goal for each visit with AF and her mother, he helped to reorient us from friendly visitors back to palliative care clinicians. And I think that begs the question, where do you draw the line? So the first thing that I'd like to talk about is boundaries and boundary crossing. Boundaries are the ideal ethical, physical, and emotional constraints that delineate the limits of a relationship and provide safety when inequality exists between two individuals. A boundary crossing is an ideal limit that has been traversed without really information about the benefit or harm to either party. A boundary violation is a boundary crossing that causes harm to one party, and in our case, the patient typically. I'd like to mention that boundary crossings aren't necessarily a bad thing, as the word boundary might imply. In some instances, boundary crossings may be therapeutic. I think one example is giving a hug to a patient. You can imagine a situation where that would certainly be a violation, and another situation where giving a hug might be completely appropriate and have a therapeutic impact, particularly in our specialty as palliative care physicians. Where boundary crossings become harmful is when they lead to the formation of dual relationships, when a secondary relationship arises in addition to the primary, which is the patient clinician. I wondered whether certain specialties are more susceptible to boundary crossings. Palliative care, where the patient-clinician relationship develops quickly and with considerable emotional intensity, and we address suffering that spans physical, spiritual, and psychological. And sometimes our interactions occur in non-traditional settings that might lead to increased boundary crossings, such as the home when we're on hospice. Pediatrics is also one specialty that I wondered whether was more susceptible to boundary crossings. There is a desire to create a nurturing, collaborative, and trusting relationship, not only with the child, but also the caregivers. And there is an intensity of emotion surrounding the care of an ill child that I think is a little bit different. So you can imagine that pediatric palliative care, where I spend a lot of my time, magnifies some of these factors. And I also wonder whether these specialties warrant more flexible boundaries. There is information in the counseling literature that suggests the benefits of the therapeutic use of self, and the idea that this allows clinicians to be authentic and engaged without losing clinical focus, that our genuine reactions and appropriate disclosure of impressions and experiences help to build trust with our patients and their families, with the caveat that care must be taken to avoid self-disclosure, which is for the clinician's benefit. These quotes are from a study interviewing patients and physicians in hospice and medical oncology that sought to understand how concepts of palliative care might improve doctor-patient relationships. They identify 5 patients of the doctor-physician relationship, one of which is establishing authenticity. And I think that these quotes kind of help to make my point. So this physician was quoted to say, "If you act like you are detached from them, it may help to keep you protected, but you don't help them." A patient reflected, "I like to feel that my doctor is talking to me as if I was his brother. I can feel the sincerity, like I'm a person in his life. We're 2 people relating to each other." But again, this requires a self-awareness that allows you to blend your authentic self with a continued professional persona. To go to my next pitfall, countertransference, as AF's clinical status worsened because of disease progression, she was transferred to the ICU. It was clear at that time to her medical teams that she was dying from her disease, and her medical teams agreed that resuscitative efforts were unlikely to be successful. A family meeting was held with AF's mother to share this information, and it went poorly and ended in her mother walking out. Her primary oncology team, which you might remember had known her for several years, started to avoid the room, and they were unable to circle back due to the fear that AF's mother was upset with them and that they had fractured their relationship. Ultimately, it was a cross-covering oncologist on a weekend who recommended limits to resuscitation for AF. So this countertransference in palliative care is the idea that that we have feelings that we experience about the patient. These feelings can be triggered from the clinician's past or feelings that are evoked by the patient, and that we attend to countertransference by separating our own feelings from feelings that emanate from the patient. And I think in this case with AF, it's this idea that there is a distress about the mother hating us, as opposed to the distress that the mother is facing about her sick and dying child. And our goal, as it often is in palliative care, is to understand the patient's values and preferences without imposing our own. And it's easier said than done. So in a large study of terminally ill patients at the time of hospice referral, a time point where some would argue in adults the prognosis is pretty clear, a majority of physicians overestimated survival. And the factors that were associated with decreased prognostic accuracy were longer duration of physician-patient relationship and a shorter time since the last contact, implying a physician that was closely in contact with their patient. One of the conclusions of this study is that the closeness and intimacy that develop between a patient and physician can impair a physician's ability to accurately estimate the patient's prognosis. There's also literature that suggests that oncologists who feel close to a patient may be less likely to stop aggressive therapy when appropriate. The third pitfall that I'd like to talk about is the potential for differences in care. As AF neared the end of her life, there was a strong desire for her to have a good death. Our nurses, our oncology team, and even our pediatric palliative care team were hypervigilant and wanted to ensure that she was comfortable at the end of her life. While we always adjust medications to optimize comfort, I wonder whether there was a blurring of objectivity on the part of the many people that were in the room to assess her symptom burden due to our own distress that she was dying. And on the last day of her life, she was comfortable but experiencing terminal delirium, and she could no longer recognize many of her clinicians. In the final hours, there was an outpouring of love, and people came from all over the hospital to visit AF and her mother. And while her mother expressed kind of how grateful she was to see how loved her daughter was by many, these visits also created a sense of fear in AF on her face because she couldn't recognize us anymore. And so to examine differences in care, I want to talk about the VIP patient, because I wonder whether we can extrapolate what we know about the treatment of VIP patients in the hospital to beloved patients, as it speaks to the same loss of objectivity. So VIP patients are anyone whose presence in the hospital by virtue of fame, position, claim, or public interest may substantially disrupt the normal course of patient care. VIP patients have been shown to have worse outcomes than non-VIP counterparts, and they induce changes in behavior and clinical practice and can lead to the provision of excess care because they do not follow practice guidelines. This is a quote from a review article in a child psychiatry journal that I think captures this idea. Just as avoidant and abridged care may serve to bind the anxiety engendered by the treatment of VIPs, overzealousness can provide a comparably damaging and opportunistic alternative. And I think this dichotomy between avoidant care and overzealousness can describe our approach to beloved patients sometimes. We can all recall scenarios where patients are offered one more intervention because their clinicians are having a hard time accepting the fact that their patient is dying. Similarly, as with AF, when we feel that we have nothing left to offer, sometimes we become avoidant because of our own feelings of guilt and inadequacy, again, requiring attending to countertransference. So how do you overcome these pitfalls? I think that first, it's important to identify when these pitfalls become dangerous, and I believe that it is when they impair objective care, when the needs of the clinician interfere with the needs of the patient, and when we feel that nobody else can meet the patient's needs. And I think that that last one has been an important check for me as I see patients, a way for me to realize when I may be getting close to approaching a pitfall. The protective measures that I think can help us overcome these pitfalls are when there's space for self-reflection and time for it, when there's supervision, which is something that's well described in social work training and education, and less so in medicine, and when there's an interdisciplinary palliative care team. So I think with AF, one of the things that was protective is that we had our own team helping us to keep checks on ourselves. And I think that the interdisciplinary palliative care team can also play a role in the hospital and help keep checks on the other teams that may be struggling with having beloved patients. So back to my idea that beloved patients can affect the care of patients and also influence clinician well-being, I'd like to next talk about the effect on clinician well-being. And as I think through beloved patients and my experiences this year, a question that I wrestle with is, do they fill our cup up and rejuvenate our desire to come to work, or do they drain our cup and make it harder to come back the next day? And while I don't know the answer yet, I think that the answer lies somewhere in the distinction between compassion and empathy. This is an article that one of our program directors, Dr. Delima Thomas, sent us at the beginning of this fellowship year, and it's one that I come back to often as I think about my own practice. This article defines compassion as feeling for another with warmth, concern, and care, and distinguishes that from empathic distress, which is feeling with another by sharing in the suffering of the other. I think that we get into trouble when we cross over from feeling for a patient to identifying with them to the point that we are sharing in their suffering, when it becomes less about them and becomes more about our own suffering. At the same time, I believe that beloved patients can protect against burnout. They're a form of meaning making that can be protective. But in order to leverage this skill, it also requires us to self-regulate our own emotions, to set healthy boundaries, whatever and however flexible those boundaries may be, and to have realistic expectations of ourselves. In conclusion, after AF's death, we had the opportunity to attend her funeral. And at that time, and in the times that we've spoken to her parents after, they continue to express immense gratitude for the love and care that AF received. I think that leads to another question: what are the bereavement outcomes of these parents of our beloved patients, which is something for a different talk. But as I think about the lessons that I learned in caring for AF and in thinking through this topic, I think that strong emotions, both positive or negative, towards patients cannot be avoided. I think that an awareness and an identification of these emotions can help to mitigate the possible pitfalls. I think that having the space and the time to self-reflect and interdisciplinary palliative care teams to help keep us in check can be protective. And at the end of the day, I'm left with the fact that I still think that beloved patients can add meaning to our work. We just have to be able to recognize that we need other skills to help keep us away from the pitfalls. This talk went very fast, I apologize, but there are many people to thank for helping me think through this topic, both formally and informally. There are people that casually had a conversation with me. There are people that sat down with me, like Dr. Groves, who wrote that first article and had a cup of tea and helped me explore this idea in the first place. And then there are people who just sent me papers that would be interesting to include. I'd like to thank my fellows who spent a lot of time helping me think through Disney images to include in my presentation. And I'd like to thank all of our adult co-fellows. And then last, I'd like to thank our patients and their families who let us be a part of their care every single day. That's it.
Thank you so much, Puja. That was fantastic. I wonder if there are questions or comments?
Puja, thank you for a beautiful talk. That was really just beautifully done, and on a topic that I think doesn't get a lot of attention in palliative care, but one that's clearly really important. My question for you is, in thinking about the beloved patient, how does that sort of intersect with our role as consultants versus the primary team, and how do we think about that?
I think that's an interesting question. I think as consultants, sometimes we have a little bit more of a bird's eye view of the patient and their care. And so I think we can sometimes recognize that a patient may be beloved by many quicker than the people that are taking care of that patient in a more primary role may. And so I think in that space, our role is often to help bring an awareness to that fact to the other teams, the primary teams that are caring for that patient, and then perhaps help them attend to some of these feelings that may be occurring. Thank you.
You touched on it, but then I want to hear you talk a little bit more about the patient who's beloved by only a few. or may actually be a difficult patient to other people. Talk about your thoughts about that. I know there's no literature.
Yeah, so actually the Hopkins study that talked about the primary care physicians and their experience with favorite patients mentioned that there were a subset of patients that had started out as difficult and had actually become favorite patients. And I think it speaks to that when you think about the clinician qualities and the situational qualities. If there is a difficult patient and you imagine going through an experience with them and coming out on the other end and being able to be the one that supported them through that, you could imagine that that patient would be beloved to that individual, but that the rest of the people that don't interact with the patient on that deep of a level may not kind of have that same attending to or same feelings. But.
Hello, can you hear me? Hello?
Oh, hello? Yeah,
Yeah,
I hear you. Go ahead.
Hi, this is Dr. Bob Taylor from Care Dimensions. Thank you, Puja. That was a wonderful talk. There's a concept in Buddhism, compassionate detachment, which I think kind of captures some of what you're describing. The other thing was triggered for me was the definition of love that I've heard, a commitment of the will to the true good of the other person. And I think one of the challenges is in America, we kind of sometimes think of love more as an emotional feeling rather than a commitment of the will. And so I think what you're discussing to some degree is that interplay between our commitment to the good of the other person and our own emotional response to the person. And I think part of what you're describing is the struggle to separate those two.
I think that's right. I think that it's interesting. I hadn't heard that definition of love before, but I think it speaks to this idea that you can be there in that space with a patient in a completely authentic way, and also when you kind of leave the room, be able to separate that and continue on to be able to take care of the other patients that you're going to see that day.
Similarly, I was thinking a little bit, and you kind of alluded to it, about this idea of countertransference as a possible pitfall, and how we kind of think about this in the counseling or social work world, and that countertransference-like feelings just are and exists, and how we manage that, and kind of alluding to what that means. And I think a lot both to the use of self in the literature that you talk about from the counseling literature, and even those 3 clinicians who said they never had a favorite patient. And I wonder so much about if you, in some of your research or looking into this, thought about people who kind of differentiate between the intentionality of how we use those things or how we think about those things versus kind of the reaction to those feelings or the countertransference that arises into us, and that the importance of that awareness of it or the intentionality in order to use it versus it being used by it, so to speak.
Right. So I think the psychiatry literature does a good job of thinking about that, and they feel that transference and countertransference both have diagnostic utility, and I think it comes from that similar concept of being able to have an awareness to those feelings and then to step back and to recognize that when I have an awareness to those feelings, I know this about myself, and that I know that this means that I'm getting maybe a little too close, and to be able to recognize to step back is kind of the way that I think as a palliative care clinician I would find it useful. But again, in psychiatry, I think that that is actually of diagnostic use to them, which is interesting.
I want to make sure we check in and see if there are any questions at Dana-Farber. Puja, I thought that was fantastic. And as someone who, a lot of us here are involved with teaching the fellows, I wonder, you're sort of almost 3/4 of the way through your year, and when you think of the arc of the year and how to teach this, Any thoughts, any pearls for us? Because I'll say when you try to bring this topic up in the first weeks, it's lost. And sometimes the reaction is, you're cruel. We should go back and see this patient twice because we're palliative care. And then sometimes it almost goes to the other extreme in my experience, come like February, they're like a, sort of a detachment. And so any thoughts on how this might be taught?
Yeah, I think you're right. I think it's really hard to have like a piece of curriculum that can teach this and fix this. And I don't think it's necessarily something that needs to be fixed, but rather explored. And so I think, honestly, I think the social workers do it the best in that having kind of scheduled time to check in and to think about these feelings, even if you're not able to name that you're starting to think of a patient as beloved, but having someone who has more experience than you be able to reflect on that with you as you struggle with caring for a patient, I think to me seems like a way to make it, to teach these skills in a more kind of genuine and authentic way. And so I wonder if there's a way for the rest of us to learn from our social work colleagues and to work that into our own practice too, where we have frequent check-ins about patients that, like Sue says, are making your SEDS meter rise, and to explore why that is together.
Great. Any other questions?
Thank you for a wonderful presentation, and I'm a social worker, and thank you for kind comments. I am sitting across from a palliative care chaplain, and would also like to add that piece of the interdisciplinary team. And I think my question is, there's so many barriers, I feel, to joint visits and fully utilizing an interdisciplinary team and striving for a transdisciplinary team. And I wonder if you have any thoughts about what might work better for fellows.
Yeah, I think it's an interesting question, and I think that there might be some differences in the way the adult palliative care teams work compared to the pediatric palliative care teams. Our structure of the day is often that we will divide and conquer visits, but that we all know about all of our patients. And often when we do divide and conquer, we divide across disciplines. And so we will put a medical provider, like one of our physician fellows or NP fellows, with one of our psychosocial providers. And I think that having that opportunity for feedback is important. And then also I think it helps when it comes to situations or patients like AF.
Question from Dana-Farber. They couldn't get the speaker to work or the microphone to work. This is from Joanne. What are the consequences of favoritism on other patients?
Yeah, I think the consequences, and I think that initial reaction of the 3 patients that denied having favorite patients is this idea that having favorite patients leads to acts of favoritism. And so I think at any point when you're worried about preferential care or differences in care, disparities in care in that way, I think that is an issue. I think the other thing with that is I think that favoritism implies kind of a crossing past the beloved patients and kind of alludes to having these pitfalls. And so I think when there are also consequences for providers, for clinicians, and that's when I would wonder if we had, if we were showing favoritism, if that would also impact our own kind of grief and bereavement of the patients as well.
I would just add one more comment, and one thing that I've seen in the beloved or the VIP patient is sometimes they have different access to clinicians, and if for some, and they go through their illness for years that way, and sometimes when that person is not available, they have no idea how to work within the system that everybody else works in. So it's one other pitfall that I see.
That's a good point, and I think one of the things that I initially explored but couldn't find much about was whether we have increased referral of patients in palliative care, of patients that are beloved or favorite patients, because clinicians who have these beloved patients that have had these beloved patients for a really long time, at a point when there might not be kind of curative options, they still want to do more for that patient, and so refer their beloved patients to palliative care as a way to offer them something more.
Well, Puja, thank you so much. This is wonderful.